So it's not infrequent that we get transfers into the emergency departments from other hospitals with a predetermined diagnosis. So just last week, we had a really great case that was transferred to us. This was a previously healthy 5-week-old who presented to a peripheral hospital with poor feeding and lethargy, no fever, and had a sick contact. Mom had a URTI, and they were admitted to the pediatrics ward, worked up for sepsis as well as non-accidental trauma, but they were also most likely thinking this is bronchiolitis. So they admitted, had antibiotics, was examined by the ophthalmologist in addition just to be safe, and also given some bronchodilators, which seemed to improve some of the mild respiratory symptoms that the neonate had. But then the following day, that deteriorated quite significantly with increasing oxygen needs and increased work of breathing. And so this patient was actually transferred to our emergency department because we didn't know if the child needed to go to the ward at our quaternary care center or whether they needed to go to ICU. And on arrival, I was called immediately into the room by the nurses who were quite concerned about the respiratory status of the child. And on looking at the child, he was quite distressed, and we didn't have a chest x-ray available immediately as it had to be uploaded to our system. So I quickly put the ultrasound probe on and looked at the lungs, and what I found was there was a bit of pleural shred as you would expect with bronchiolitis, but there was a lot of B-lines, way more than you would expect with your typical bronchiolitic child. And so this made me think that perhaps there was maybe pulmonary edema going on, and prompted me to look at the heart and the IVC. And what we ended up finding was very abnormal anatomy. There was a third atrium, there was an AST and VST visible, as well as when I looked at the IVC, there was an extra vessel coming in below the IVC. Extremely abnormal. I didn't know exactly the diagnosis, but I knew that this was not just a bronchiolitic, but probably a baby that was in congestive heart failure secondary to cardiac or congenital cardiac abnormality. And so ICU came down, and I had let the resident know, and as soon as the patient went up to the ICU, cardiology consult was initiated, and an echo confirmed that this baby did have, in fact, 3 atria as well as the AST, VST, and a partial anomalous venous return. So this really did change the management as well, as because I did not end up giving any fluids in the emergency department nor any more Ventolin, despite the apparent wheeze that the respiratory therapist and the nurses were hearing. So in the end, this was a great example of how ultrasound can really alter or reverse your cognitive bias. This baby was presented to us on transfer as a bronchiolitis, but ended up having a congenital cardiac anomaly. In the end, this baby was intubated in the ICU as they deteriorated from cardiogenic shock, and that night went to get a balloon dilatation of the ASD and VSD, and also the obstructed part of one of the atria, and later went on to have correctional surgery. This baby probably did have an element of bronchiolitis that pushed the child into cardiogenic shock. But it was really ultrasound that changed how we managed this patient and the earlier discovery of the actual cause of decompensation. If you like what you saw in this video, please remember to like and subscribe.